Priyadharshini, one of the mentors at Study Medic, and in today's video, we are going to see about the clinical management in gynecology, wherein I have taken few important green top guidelines, which we are going to discuss in detail. The discipline, dedication, and determination will definitely take you very close to your success. Let's start up with some questions. We have a 35-year-old woman who is attending the outpatient department with an incidental ultrasound finding of a 4 centimeter ovarian cyst. What is the most appropriate plan of management? Now, when you come across such an SBA, what are the important things you need to keep in mind? First thing is the age of the woman. We see she comes in the premenopausal age group of 35. Second thing, what are the clinical features she's presenting with? It is just an incidental finding, so she's an asymptomatic woman. Third thing is we have to look at the cyst features, which is just a 4 centimeter simple cyst. So, based on the findings that we already have with us, we are supposed to choose the most appropriate plan of management. Well, considering further imaging or an intervention in the form of laparoscopy or further testing like CA-125, or we are left with reassuring and discharging the woman, or are we going to offer her a yearly ultrasound follow-up? But based on the features that we have in mind already that's provided, we are going to reassure and discharge the patient. Why? Because we are going to follow what the green top guidelines have to offer us, where we are going to talk about the premenopausal ovarian cysts. Now, this is what I was telling you. This is the algorithm taken from the guideline. And here we see the criteria will depend on this presentation, whether it's an emergency presentation wherein an emergency surgery is required, preferably laparoscopy, or if it is an asymptomatic woman, we'll be looking at the cyst features like the size of the cyst and whether the complexity, whether it is a simple cyst or complex cyst. Complex cyst always warrant tumor marker evaluation. Simple cysts do not. And for simple cyst, if it is present for a long time, if it is completely persisting, or if the woman becomes symptomatic, then yes, we are supposed to advise the woman to undergo tumor markers as well as further testing in the terms of MRI. If not, then usually we reassure and discharge the woman. And also to note that whenever we have a suspicion of malignancy, we involve the gynec oncology MDT also. So now let's look into further scenarios. We have a 32-year-old woman presenting with left-sided pelvic pain. She is otherwise very well, which has got regular periods. We have an ultrasound which is showing a 5.5 centimeter simple unilocular ovarian cyst. There is no solid areas or papillary projections. Markers are again normal. What is the most appropriate management? Now, it's again looking at the age, 32 years. And she has a little bit of pain. Yes, that is one character we have to keep in mind. But the ultrasound, it is just a 5.5 centimeter simple cyst. Tumor markers are negative. And again, it is only having the benign features and there are no malignant features. So what are we going to do with her? Yes, because it is because of the size and because of the pain, is our management option going to vary? Think about it. Looking at the second question here, we have a 44-year-old woman who has not got any significant history, but now she has a 6 centimeter multilocular cyst with very thin septations. But again, if you look, there are no solid components, there is no ascites, and she is asymptomatic. So absolutely no symptoms. CA-125 is 18. So what is the best next step in management? So the age is 44, it is asymptomatic cyst, and it is 6 centimeter multilocular. So if you actually look into the first scenario, again, it is premenopausal, it is simple cyst. So it can be a functional or a benign cyst. So you can put her into observation like conservative management and we can repeat the ultrasound. Okay, so repeating the ultrasound will give us an idea of whether this is going or it is still present. However, to note the same scenario, if it presents as a very severe lower abdominal pain, then you will have to offer her some intervention because you need to think in terms of torsion there. Coming to the second scenario, though it is a multilocular cyst, we need to understand that the CA-125 is within the normal limit. So you can still offer her a conservative management and repeat the imaging in 6 to 8 weeks. So that is more than enough for both the scenarios. Also, another type of questions that you can expect are based on the images. Image A, if you see carefully, it is in all these three images, A, B, and C are of ovarian cyst, but however, the ultrasound features vary between each of them. If you look at image A, we have a hyperechoic area which is clearly marked inside. Image B is clearly having gray granule-like appearance completely, and image C is completely clean. It is completely black, right? So image C is that of a simple cyst. Image B is that of an endometrioma. A typical ground glass appearance of an endometrioma is what we see in image B, and image A is that of a dermoid cyst, wherein we have mixed echogenicity, and the small white speculations are suggestive of the calcium deposits. So this is how we differentiate between the various type of ovarian cysts based on the ultrasound images that are provided to us. Now, I'm also giving you some quick bites for easy revision. Follicular cysts are usually present in the reproductive age group, and they're very small ones, and they usually resolve spontaneously. Corpus luteal cysts, they're thick wall cysts. We have to keep in mind that they have the similar features of an ectopic, sharing the ring of fire on the Dopplers. And theca lutein cyst, okay, especially in the molar pregnancy, we see a lot of multilocular cyst bilaterally present in both the ovaries. And hemorrhagic cyst can appear in any age. And the typical feature of an hemorrhagic cyst is having reticular or lace-like patterns. Coming to endometrioma, as we just saw, we have a typical ground glass appearance of the endometrioma. Dermoid will have mixed echogenicity that is seen there. And then coming to adenoma. So serous cyst adenoma is usually unilocular or multilocular, and they're very, very thin walled. Same with the mucinous cyst adenoma also. We usually have multilocular and very low echoes that are seen in mucinous cyst adenoma. Coming to para-ovarian cyst, they are usually separate from the ovary. They are away from the ovary, and they're usually thin-walled cyst. Now, in ovarian torsion, the most characteristic feature is there is no blood flow that is seen in a Doppler. Okay, or you have something called as the whirlpool sign that you can see in an ovarian torsion. Coming to polycystic ovaries, there'll be more than 12 peripherally arranged follicles. And suppose if you have a very higher end machine, you can have more than 20 peripherally arranged follicles also seen. And the ovarian volume is usually more than 10. But as per the Rotterdam criteria, we take the cutoff of more than 12 follicles. And then looking at another important concept where we have the RMI calculation. RMI is called as the risk of malignancy index. Now, what is this? This is a criteria which is going to help us understand that whether a particular cyst is more suggestive of a malignancy. Are there chances of an increased malignancy in the given cyst? How do we calculate? We use three different parameters. One is the age of the woman. If she's premenopausal, we assign her 1, and if she's postmenopausal, we assign her 3. And next will be the CA-125 levels, which we take from the blood, and we look at what the level is, and the ultrasound features. Now, in the ultrasound, we have looking at 5 different features. If none of them are present, we give a score of 0. If any one is present, we give the score of 1. And if anywhere between 2 to 5 features are present, then we assign a score of 3. So what are they? In ultrasound, we look whether the cyst is unilocular or multilocular. So multilocular gives a score of 1. Solid, bilateral, ascites and metastasis are the other features we note in the ultrasound. So based on this, we calculate the RMI. Now, whenever the RMI scores goes more than 200, that means the patient requires a specialist consultation. So let's again understand some questions here. RMI score is for assigning the risk of ovarian cancer. So what is correct with regards to the basis of calculation? So we just saw what an RMI is. So in RMI, first thing is the ultrasound score, the menopausal status, and the CA-125 levels, which corresponds to option E in the question. And RMI is a very, very important concept not to be missed for your exams. So this is the implication of knowing an RMI. An RMI less than 200, which is a low score, is generally, we do not call in for an oncological evaluation, but whenever it's more than 200, we require an oncological evaluation. So coming to all kind of postmenopausal cysts. Now, postmenopausal cysts, even 1 centimeter cysts are given a lot of importance. And an RMI calculation is definitely mandatory here. And whenever we have the RMI less than 200, we know it is a low risk of malignancy. But however, we have to look at the features of whether the woman is symptomatic or no, looking at the size of the cyst, and again looking at whether it is unilateral, bilateral, or whether it is unilocular or multilocular. So all these features will be taken into account before we have the final management plan. And whenever we have an RMI of more than or equal to 200, we are going to advise the woman for further investigations in terms of CT scan, and we're going to refer for a gynec-oncological MDT review. And on the MDT, if we have a very high likelihood of malignancy, then of course we're going to go in for a laparotomy, which is done by a trained gynec-oncologist. And if it is a low risk, then again laparotomy, but however, it can be done by a gynecologist itself and not requiring a gynec-oncologist. I don't know. We need to understand for persistent to post-ovarian, postmenopausal cyst, if it is persistent, then they will require follow-up in term with TVS and CA125 because the risk of malignancy index need to be calculated at every visit if the woman is going to be placed for a conservative management. Because for conservative management, if you see every 6 months, we're going to call in the women and with every follow-up. Now, if you see the first column that is mentioned here, we are giving a conservative management, then we need to repeat the assessment in 4 to 6 months. Now, what happens in 4 to 6 months' time? If it is still the same, if it is persistent or unchanged, then we are going to have another assessment. So, with every assessment you do, you are going to do the CA125 and the ultrasound because only this is going to guide us with the RMI scoring. And based on RMI, we are going to decide if we are going to give some intervention or no. This is another classification which is called as the IOTA classification. The IOTA classification again gives us an idea between the benign features and the malignant features. Now, what are the benign features you see here? Benign means you have a unilocular cyst. We have the presence of solid components with the largest diameter being less than 7 millimeters. It can be a smooth multilocular tumor. There are no papillary structures or very minimal papillary structures, and there is no blood flow. If these features are present, then we take into a benign cyst, and also there should be presence of acoustic shadowing. All these are the classification features of iota which are suggestive of benign cyst. Now coming to malignant features, what are they? You can have an irregular solid tumor. There can be presence of ascites, presence of at least 4 papillary structures which are seen growing into the cyst, or it is a multilocular cyst and it is irregular and the size is more than or equal to 10 centimeters, so 100 millimeter cyst. And on the Doppler image, we see a very strong blood flow. Any of these features are suggestive of malignancy as per the IOTA classification. Now let's again understand some scenarios wherein we are involving the postmenopausal women. Now, for the postmenopausal woman, if we have a 61-year-old postmenopausal woman and she is attending for a routine pelvic scan and she is asymptomatic, ultrasound is showing a 4.5 centimeter simple unilocular ovarian cyst with smooth walls and no solid components. The CA125 level is 14. So, what are the features you are supposed to note from this question? First is the age, 61, postmenopausal. Second thing, features, it is asymptomatic. Third one is the size, which is 4.5, and it is unilocular. No solid components. CA125 is 14. So what is the first thing you're going to do? You have to understand what is the RMI scoring here. So the RMI for this particular patient is going to be a score of 3 for postmenopausal status. And coming to the ultrasound, it is a unilocular ovarian cyst. That means we give a score of 1 and CA125 level is 14. So 14 into 3 is going to be the RMI and we know it is very low. So next step in management, remember postmenopausal cyst, RMI is definitely there. And once you do the RMI and when you know it is low, what are you going to do? You can offer her a conservative management and do a follow-up with ultrasound and CA125 in 4 to 6 months. Now coming to the second scenario, we have a 66-year-old postmenopausal woman. Second thing is abdominal bloating and early satiety. So look at this, is very important because she's got features. Next, in an ultrasound, you have a 6.8 centimeters, multilocular cyst, papillary projections, ascites. Okay, so there are 3 ultrasound features here, which one is multilocular, papillary projection, and ascites. Understand that the RMI scoring is not bothered about the cyst size. And the most important next point to note here is the CA125 value, which is 280. So here itself we have CA125 clearly about 200. That means it is very, very suggestive of malignancy. So this woman will require an urgent referral to the gynec-oncology because it is highly suggestive of a ovarian malignancy. Okay. Now, going into the next topic, which is on endometrial hyperplasia. Now, endometrial hyperplasia, what do you understand by this terminology? It is basically an irregular proliferation of the endometrial glands, and you also have an increase in the gland to stroma ratio. And if you look at a proliferative endometrium, we are not going to see this particular feature. The most common presentation of this endometrial hyperplasia is going to be an abnormal uterine bleeding. They can have heavy menstrual bleeding or intermenstrual bleeding. Now, the revised classification by WHO is we have two types, that is hyperplasia without atypia and atypical hyperplasia. So this is how the microscopic features are going to be there. The cells appear atypical, irregular, and quite crowded in atypical hyperplasia. Whereas in endometrial hyperplasia without atypia, the cells are not going to be atypical. Now let's analyze some questions that can come from this topic. We have a 47-year-old premenopausal and she undergoes a hysteroscopy because of complaints of severe menorrhagia. The histology is showing simple hyperplasia. So what would be the most appropriate recommendation for this particular woman? Are we going to commence her on HRT? Are we going to do a hysterectomy? Are we going to insert an LNG? Are we going to do an ultrasound? Or we are not going to offer her any treatment? So even if you have no clue about the topic, let us see how do we do by exclusion. First one is she's got severe menorrhagia. So obviously you cannot defer her treatment. No treatment is required is ruled out here. Ultrasound scan in 6 months. Right now you need to treat her, right? She's come with severe menorrhagia. So again, that option is ruled out. So we are left with three options. Are we going to give her HRT? Understand hormone replacement therapy is for menopause and it has no role for a woman who has got severe menorrhagia. So we are ruling out hormone replacement therapy also. So we are left with two options, which is either hysterectomy or insertion of LNG. Now, compared to hysterectomy, LNG is a minimally invasive procedure, and hysterectomy removal of the uterus is definitely not offered as a first line management. Okay, so we are left with the option of insertion of an LNG, which is a levonorgestrel intrauterine system. So, even if you are not sure about any topic, you can still rule out the options by exclusion and you can land up with the right answer. So insertion of LNG IUS is definitely considered as the first option here. Now, this is a very important algorithm, which is the management of endometrial hyperplasia, which is your green top guideline number 67. So what does this say? This says that whenever you have a case of endometrial hyperplasia, we classify the woman as atypical hyperplasia and endometrial hyperplasia without atypia. Now, all atypical hyperplasia, we need to know that it has a very high risk of turning into malignancy. So, we generally offer them total hysterectomy with or without a bilateral salpingo-oophorectomy. But what if the woman is not got the right parameters to undergo a surgery? A surgery is contraindicated the woman, or we see that the woman is having some fertility desires. So, well, in these women, we need to offer them the treatment options as we offer for any woman who has got endometrial hyperplasia without atypia. So, what are the things you look here? You look into the risk factors, whether we can put her into observation, or whether we can offer her LNG IUS, or whether we can offer her oral progesterones. So oral progesterones are usually considered as second line of management. Now, whenever we are giving any of these to the woman, we need to repeat the endometrial biopsy. And the repetition is going to be after 6 months in case of without atypia. And for atypical, it is going to be seen in 3 months. And what are we going to see? We are going to see whether the character features in the biopsy have regressed, whether it is persistent, or whether it is progressing into the next stage. So if whenever there's a regression, then we can continue the LGIOS or we can stop the oral progesterone in 6 months' time, or you can still give her the option of TAHBSO if she's still having the problem of abnormal uterine bleeding. And then you can arrange for follow-up. Okay. In the follow-up, you need to see that BMI is given a lot of importance. Whenever the BMI is more than equal to 35, that means she's again at a higher risk of developing endometrial tumor and she needs to have an annual review. She needs to have an annual endometrial biopsy. However, low BMI, that means she can be discharged if the endometrial biopsy turns out to be negative at 6-month interval for at least 2 times. If it is atypical hyperplasia, then again we'll have to repeat the biopsy once in 3 months. Now, what if it is progressing? If it is progressing, that means atypical hyperplasia will progress to endometrial carcinoma, and endometrial hyperplasia without atypia will progress to atypical hyperplasia. So, depending on what is the current biopsy status, we need to treat them. So what if it is not regressed, it is not progressed, it is still the same, it is persistent. For persistent cases of atypical hyperplasia, we need to advise a woman to undergo a total hysterectomy with or without a bilateral salpingo-oophorectomy. And for cases of endometrial hyperplasia, again, we'll have to see what is happening with her. If whether she was only on observation, whether she was on LNG-IUS, all this needs to be taken into consideration. And suppose if it is still, she's on a medical management and still the persistent symptoms are there, then we'll have to advise her total hysterectomy with or without a PSO. This is very, very important. So this guideline, there can be many number of questions you can expect here. And you need to understand, when are we going to offer her LNGIUS? When are we going to offer her a total hysterectomy? And what is the follow-up like? So let's look into some clinical scenarios here. We have a 52-year-old woman who's presenting with postmenopausal bleeding. The endometrial thickness is 10 millimeter. The biopsy is showing a complex hyperplasia with atypia. So what are you going to do? Are we going to give her progestins, repeat biopsy, hysterectomy, LNG, or observation? Well, endometrial biopsy is showing complex hyperplasia with atypia. Okay, so this is very high risk of endometrial cancer, which has been missed in the endometrial biopsy. Okay, second thing is the age, 52 years, so it's completed family, and it's postmenopausal bleeding. So we'll have to offer her a definitive management here, which is going to be hysterectomy. Coming to the second scenario, we have a 38-year-old woman. So remember, she's in the premenopausal age group. She's got PCOS and she has irregular heavy menstrual bleeding. And there's a thickened endometrium on an ultrasound biopsy showing simple hyperplasia without atypia. So what is going to be the appropriate first line of management? You can offer her cyclical combined oral contraceptive, or are you going to offer her LNG IUS or hysterectomy, estrogens, or diagnostic hysteroscopy? Okay, so this woman, you can offer an LNG IUS because that's the first line of management. The only thing you need to keep in mind is whether she's got fertility desires, because LNG IUS cannot be used for fertility desires. So we have discussed three important guidelines here. One is the premenopausal cyst, the postmenopausal cyst, and also all the important concepts behind them, like the IOTA classification, the RMI calculations, etc. And also we have seen on endometrial hyperplasia. Hope these slides were helpful for your presentation, for your preparation for your upcoming MRCOG Part 1 exams. Thank you.